Good morning and welcome everybody to day 2 of IDEA's regional conference on rare diseases in Malaysia and Asia Pacific. Welcome everybody to those who are joining for the first time today, and then welcome back everybody who also joined us yesterday. Very grateful for those of you who are attending for both days. I think we had a really great discussion yesterday around financing, but actually which touched on broader topics in the rare disease landscape, and I was really grateful for the sort of the level of input and audience engagement that we had. So I hope that we can continue in that spirit. Today we are focusing on regional collaboration, which we already came up several times yesterday. I think that particularly this year, when Malaysia is the chair of APEC, there's a particular focus on how Malaysia can work with partners to improve the ways in which we tackle rare diseases, both in terms of more technical collaboration, exchanges, but also through patient group networks and how that can be used to kind of coordinate advocacy efforts. So that's something that we want to drill into today, and I'm very excited that we have a set of extremely interesting and varied speakers joining us from across the Asia Pacific region, from Thailand, from China, from Korea. So I think we shall have a really good discussion today. As with yesterday, please feel free to share questions throughout the morning session in the Q&A box. And then I'll try to pick up on as many of those as I can during the panel discussion. So I'm very excited to start with our opening speech from Dr. Eileen Lee, the director of the Asia Pacific Alliance for the Rare Diseases organization. Dr. Eileen Lee has had extensive experience in the healthcare market and rare diseases specifically, and is a well-recognized rare disease expert in China. She joined the Chinese Organization for Rare Disorders as a senior consultant in 2015, and has been working closely with them in rare disease policy advocacy, including leading multiple high-profile reports. Eileen is also a director of the Asia Pacific Alliance of Rare Disease Organizations and the project consultant of the International Rare Disease Research Consortium. She has accumulated a rich experience in registration and approval, pricing, reimbursement, and the go-to market model of rare disease drugs. So I'm sure that Eileen has a lot to share with us in terms of the regional perspective in the rare diseases landscape. So on that note, I'm very honored to pass over to Dr. Eileen. Dr. Eileen, please.
Yes, thank you, Lawrence, and thank you everybody for joining the meeting. So I'm gonna share my screen. Okay, can you see my screen?
Yep, we can see that very clear. Thank you.
Okay, great. So today my topic is about the rare disease regional collaborations, but I think I will go for two perspectives. One is from China side, from CORD, what we have done in the past in the collaboration. And another perspective is from APED side to talk about something in the larger region in APEC. Okay, so first I will introduce in the past years what we have done in China. So here is a very basic introduction and a recap of China rare disease community, the most updated status. We know that 2 years ago in China, so for the first time, we had a definition for rare disease. It was by the catalog of the first batch of rare disease, which include 121 rare disease. So it has become a very good signal that in China, we have some definition for rare disease. And also in China, in the nationwide, we have started to do the national rare disease diagnosis and the treatment center. We have currently 1 national leader and also more than 300 regional rare disease hospital centers to do the diagnosis and the treatment work. And also another very important action is from 3 years ago in China, we have the national reimbursement drug list updates and also the negotiation. Since 3 years ago, more and more rare disease drugs, they became to be included by the national reimbursement drug list. So that means Chinese government started to pay for rare disease drugs. So it's very a positive signal. And also in the regional level, we know in China, we have more than 30 provinces and more than 300 cities. In the regional level, also some provinces and cities, they started to reimburse rare disease drugs using their local funds. So in the past year, we have seen like more than 9 rare disease with 10 rare disease drugs have been included. But still in China, there is some gap with the global community. First thing is that more than half of the 3 million patients cannot be diagnosed because of the low disease awareness. And the second one is most of the treatment solutions still are not available in China market. Patients, they have to purchase drugs from the overseas markets, for example, Turkey or other European and US markets, which in most cases is illegal. Last one is most patients, they cannot receive compliant and consistent treatment. So a lot of disabilities caused by rare disease is very common among the patients in China. So here we know the context in China is we have 3 very biggest unmet needs. First one is rare disease treatment solution availability and accessibility. The second one is still we lack a reimbursement mechanism in the nationwide, especially for those very high cost ultra rare disease drugs. The third one is still the rare disease diagnosis and the treatment, the routine guidelines. To some extent is still absent in China for many rare disease. So in this context, Chinese Organization for Rare Disorders, we also call that CORD, we have done a lot of things around these key unmet needs for rare disease patients. The first thing is a very fundamental thing, is to incubate more and more single rare disease patient organization, and also to coach them to do the policy advocacy, to do the disease awareness, public relation communications, and also so in the past years, we have organized more than 13 national patient organization network trainings. It's all nationwide, and more than 90 patient organizations, and also like 600 patients and leaders, they participated in the national network trainings. And also we have offered more than 60 rare disease training courses to tell them how to do the disease education among the patients group, and also how to do the drug accessibility advocacy in China society, and how to provide high quality services to the patients within their organization, and also how to engage with multiple stakeholders in the rare disease industry, for example, with HCPs, with hospitals, with pharmaceutical companies, and also with government policy makers. So this is a very fundamental thing CORD has done in the past years. The second thing is also very important, is very nationwide rare disease awareness promotion, and also the international communication. So we, CORD, we have already organized 9 China rare disease summits, very national conferences in the past 9 years. And this year, it's a 9th summit. It is organized in Chengdu, in the southwestern part in China. And during the conference, it's a 2-day conference on site, and we have organized a lot of key topics. For example, the diagnosis and the treatment of the rare disease, and also the reimbursement, the payment policies environment in China for rare disease, and also the research and the development for rare disease solutions, and how patient organization can help that. And also the rare disease commercialization and the innovation in the future. And also we have a special session is about how to collaborate under the COVID-19 context. And also in this year in Chengdu in the conference, we have invited some speakers from international community, for example, from Taiwan, and Ruth has participated to introduce how they coped with the COVID-19 during the during the context. And also we have invited speakers from Slovenia and from other European markets to share their experiences. So it's a second very important thing core that we have done in the past. The third thing is also Lawrence just introduced the core that we have do a lot of web papers to do the policy advocacy in China. Since 2019, we have published the first very influential white paper about the rare disease drug accessibility in China. It's a very comprehensive report. It was for the first time that somebody in China we have come the very whole picture landscape about rare disease drug accessibility. So it's the first white paper we have done cooperated with IQVIA, which is one of the largest healthcare consulting institute in the global market. And also followed by another white paper, the second one is about how patient organizations can support rare disease solutions, research and development in the China context. Also, we have introduced the global experiences in how PO support rare disease R&D. The third white paper is published in this year. It's in a very reimbursement perspective. We have do a very comprehensive research in the city level in China to illustrate how rare disease patients, their accessibility to the solutions in China and what's the gap and how to solve the problems in the future. So basically the three white papers have reached a huge social attention and also attention from the government and policymaker side. And in the past 1 year, I also participated in a lot of the regional government sharing meetings to introduce the key outputs of the three reports. And also we believe that currently in China, from the National Reimbursement Bureau to the provincial or city level reimbursement government offices, almost everybody, they have at least 2 reports by court. And they have that on their hands to learn from the reports. And also next month, we will also release another very important report. It's in the local level. It's about the Hunan province, the rare disease patient report in that region. So policy advocacy has already become one of the very important work by court in China. Another thing is court, we have been very actively to do the industry bridging work. So the right side is, we know it's a very typical rare disease value chain from in the very beginning, the portfolio prioritization to the R&D, to the patient, to the drug registration, and also to the product launch, and also to the real world. So it's from the industry perspective. And the core, we know that it is very important to understand the rare disease industry unmet needs and their perspective, and then to do the bridging work between patient, HCPs, and also the pharmaceutical industry, as well as with hospitals. So in the past years, to bridge the different needs from the multiple stakeholders, we have to 5 very important actions. First one is to establish the patient registry, to tell the industry, to tell the society how many rare disease patients there are in China. Second one is we have been helping to do the patient recruitment for the new therapy clinical trials. Third one is to support to do the patient needs investigation to tell the industry which kind of unmet needs are the key among rare disease patients, to tell them the research and the development direction in the future. And also we support to the patient-reported outcome connection by different single rare disease. And also we participate in the patient follow-up services. So basically it's how we engage with multiple stakeholders along the rare disease value chain. Also, another thing is very important. We know this year is very special, 2020. We have COVID-19 in global wide. And so in this year, we have also do something around COVID-19. In the 9th Rare Disease Summit in Chengdu in this year, we have issued the first special fund for anti-COVID-19 in rare disease area. We have raised a very interesting fund to encourage those patients and also all their families who have been contributing in fighting for the COVID-19. So we have already released the first batch of awards in this September during the conference. So the right picture is actually the award ceremony. We have released the award to more than 19 rare disease patients and organizations. And we give them cash directly to encourage their contributions. And the awards are like $4,000 or 3,000 or $1,500 to these patients and families and organizations. And from last month, we have also initiated the second batch. So maybe soon we will finish the second batch list of the patients and organizations who can receive the award. So we call this Rare Safeguard Fund program. And also all of China, we have also do some donation work and connection to the international community. In this March, we have received a letter from Slovenia, the William Julian Association for Children with Rare Disease. We received a letter from them to ask for masks donation. And soon we have engaged with multiple stakeholders, for example, the single donors and also the pharmaceutical companies. So very quickly, we organized to donate 8,000 masks to Slovenia. And these are pictures, they received the masks from China. And the right side is a list of the 8,000 masks and how they distribute this in different hospitals and centers. So we think it's a very remarkable action that, during the global-wide COVID-19, how rare disease patient organizations, so we can help each other within the domestic context or in the international context, we can help each other to do something. Okay, so from this slide, I will introduce another perspective. It is from APED, from a larger region side. So what APED we have done or we are going to do in the next years in the regional collaboration. So I want to start from our 3-year action plan. So this 3-year action plan is issued in this year. We have 3 strategic objectives. First one is to identify the gaps between patients' unmet needs and also the existing policy on rare disease in specific countries in the region. The second one is to promote the tri-party or multiple stakeholders engagement like government, NGO, and also the industry part to improve the collaborations to address the rare disease issues. The third one is to mobilize and also to empower and to build up the network for rare disease patient leaders in the region level. And also we have 4 focus areas. First one is diagnosis. Second one is orphan drug policies. Third one, treatment, and also coordinated patient-centric care, sorry, it's a typo, and also the financial and social support. Around the three objectives, we have yearly activity plan by 3 years. Also, I listed the 3-year plan here. The first year plan is to have the annual conference, and which is coming in this December. And the second one is to organize the online forum for members, industry partners, and other stakeholders, which aims to promote the multi-stakeholder engagement. And the third one is regional survey. We know this year is special on the impact of COVID-19 on organizational efficiency. And the last one is to initiate some engagement in the regional level, for example, 1 to 2 countries for the gap analysis. So basically this consists of the main activities what are part of we are going to do or we already have done in the regional level. And so, for example, in this year, during the COVID-19, APED has done very important research work, which is to raise a report about managing rare disease in APEC during COVID-19. And it is cooperated with Hong Kong, the medical community from the University Department of Pediatrics and Adolescent Medicine. And we together do this, and we have issued the surveys to patient organizations in the APEC region to ask them if anything, any hurdles, problems they have encountered after COVID-19, and to know their status this year. And also we have, in this report, we have come out 4 suggestions to the patient organizations in the region. The first one is to be aware that the urgent mental health support is needed for rare disease patients. The second one is there is a need for funding of special projects that can support the resilience and preparedness. And also the advocacy training is still important to improve the capacity within the POs. And the last one is to facilitating the access to reliable sources of information, and also the expertise among the rare disease POs. So this is what we already have done in the last months. And also another thing is in the larger community collaboration, is the first one is APEC rare disease workshops. We have also participated in this, and together with the UN, WHO, and also APEC rare disease framework, and also to do the coordinations to support in the workshops. And the second thing is also maybe I think a lot of people we have already participated in this is a collaborative global network for rare disease. We have do the focus groups in the past months, and to collect voices from different regions, the patients there. And also we have a coming activity I also mentioned earlier is a part of annual conference, which will be held during the December, the first 2 weeks. Basically, I think what APED will do in the next days is continuously to promote the National Rare Disease Action Plan in the APEC region to see something happen in the future. Okay, I think today my sharing will stop here. And also here I show the 2 important reports by court. Also I listed the QR code here. If you can scan that, you can enter into the report page to know more about the 2 reports. So thank you everyone online. I will stop my sharing here.
Thank you very much, Dr. Eileen. Very interesting, and I think we'll definitely be keen to ask you some follow-up questions about how some of those achievements have come about, and I've already seen a few questions on that topic. But I'll move swiftly on to my colleague Vaishnavi. So yesterday I presented on the trust fund, our policy research on the trust fund option, but today Vaishu is going to present the second half of that work, which really drills into regional collaboration by trying to learn lessons from European examples. So most of our discussion today is taking the Asia Pacific perspective, but now Vaishu is going to present on the European dimension. So over to you, Vaishu.
Thank you, Lawrence, and good morning to everyone. I'm just going to quickly share my screen. All right. So today, as Lawrence said, I will be presenting the second half of our publication that was released yesterday. And this is really focused on 2 case studies from Europe that we really examined and tried to get some lessons from in regards to regional collaboration, specifically to improve sustainable access to innovative medicines. So just before we go into the case studies, I just wanted to highlight that, as we mentioned multiple times yesterday, regional collaboration can really take place in multiple areas for rare disease. And I think this was mentioned a few times yesterday, the need for a more holistic social care alongside healthcare delivery. So this is one aspect of regional collaboration that can take place. Another aspect is exchange of clinical expertise. With the large number of rare diseases that exist around the world and a very small number of expertise and clinical geneticists and clinical counselors, genetic counselors available, there really is a need to share that expertise across the region to improve diagnosis and guidelines. Moving on, we also need and can benefit from regional patient registries. This would obviously be a very taxing task, considering that a lot of the countries within the region are just in the phases of improving and developing their own national registries. But it is something that can be more of a midterm goal that we can strive towards. And finally, on regional platforms to create sustainable access to innovative medicines. As we mentioned yesterday, IDEAS has taken the focus on looking at the funding policy aspect of rare disease. And hence we focused on looking at regional collaboration specifically to improve and create sustainable access to innovative medicine. So my presentation today would really focus on 2 case studies on regional platforms that have been created to achieve this aim. So when we talk about regional collaboration to create sustainable access, there are often cross-cutting goals that are seen in most of these platforms. And this is basically joint horizon scanning, information sharing, joint health technology assessment, and joint price negotiation. So with joint horizon scanning, what we mean by that often is the aim to highlight pharmaceutical innovations as they are entering the market. And this really helps countries continually gather data and analyze the research on the different products that are entering the market. And this allows them to, enables them to make timely decision making and really plan around their strategy on how they're going to go about improving access. Beyond that, there's also the benefit of information sharing, and this is often done on medicine policies. So with medicine policies, this regional collaboration can really serve as a platform to share best practices on how respective countries go about their medicine policy and practice. And besides that, we also have a joint health technology assessment. And this is often one of the more important goal within the initiative. And with joint health technology assessments, the way it's done is that the collaboration often happens on a supranational level, collaborating to basically have a mutual recognition of respective national assessments. And then this may or may not lead to the reuse of different assessments for specific products. But as of 2019, a lot of the trials and pilots that have taken place often do focus on the just the mutual recognition of national assessments and not so much on the reuse of HTAs. And this is often done with the end goal of reaching joint price negotiation or procurement. And this is done to seek more price transparency on cost buildup for pharmaceutical companies, and also with the aim of, if possible, pooling purchasing power and eventually improving access. So our first case study that we looked at is the Benelux initiative. This began in April 2015, and it was a collaboration between health ministers of Belgium, Netherlands, to carry out price negotiations specifically for orphan drugs. And they were further joined by Luxembourg in September 2015, and then Austria in 2016, finally Ireland in 2018. And their sort of collaboration really cuts across all the sort of goals I mentioned in the previous slides on joint horizon scanning, health technology assessment, exchange of information, and joint price negotiation. When it comes to their activities in regards to information sharing, their platform was really used to facilitate a sort of mapping exercise of biosimilar landscape. And this is really useful in respective countries to be able to then share with other countries on their sort of landscape on biosimilar and generics. And this has also, this platform has also been used to sort of attempt to have collaborations on patient registries, but this has, however, unfortunately, been limited by the sort of legal frameworks within the respective countries. Another important activity is horizon scanning, and for Benelux, this is done through the IHSI database. And this platform is basically there to share information on companies' pipelines, and it really does help governments improve their plannings. And not just government, it's also important for healthcare professionals and public payers to really understand what's out there and how they can plan better to really bridge that gap in access. However, I do want to note that as much as there is a database out there, it is very much dependent on how the government sort of use that wealth of information and how much they're going to benefit from the component of horizon scanning in this initiative. Joint health technology assessments have been done through Benelux, and between 2015 and 2017, they explored about 4 different drugs, so joint HTAs for 4 different drugs. But most notably in 2018, Belgium reused Netherlands' existing report on Spinraza, which is a drug for spinal muscular atrophy, in collaboration with the pharmaceutical company Biogen. And I'll come back to this again later, but this eventually sort of led to joint negotiations on Spinraza by both countries. Beyond this 2018 sort of case study, within this case study, there was reuse of parts of assessments that were carried out for other products. But as of November 2019, the sort of furthest it has reached is mutual recognition of work. So I just wanted to give a brief sort of timeline. I mean, Benelux has not existed for a very long time, but in 2017, there was a negotiation attempt done over Vertex's or Orkambi, which then resulted in a negative reimbursement decision in 2017. And moving back to our example in 2018, Belgium and Netherlands was successful in carrying out a joint negotiation of Biogen's Spinraza drug. And this was sort of done very differently and implemented very differently in both countries. So in Netherlands, Spinraza was to be reimbursed for patients up to age 9.5, subject to sort of the effectiveness of the drug, whereas in Belgium, all age groups was to be covered. And as of 2019 and this year, there have been no further successful negotiations that were carried out. I do want to make a note that the sort of success of Spinraza in the negotiation of Spinraza in Belgium and Netherlands and the sort of different implementation really highlights a key strength of these initiatives. Although joint HTA and horizon scanning, information sharing, and all the different stages of collaboration took place, when it came to the joint negotiation, implementation can really take place in respective to the needs of different countries. So there isn't this sort of need to sort of move together consistently throughout all stages. So moving on to our second example is Valletta Declaration. And this was founded in May 2017 in La Valletta by Cyprus, Greece, Italy, Malta, Portugal, and Spain, and has since expanded to include Croatia, Ireland, Romania, and Slovenia. And their activities are very similar to Benelux in that they cut across all the different goals of joint HTA, sharing of information, exchange of information on pricing and reimbursement, and horizon scanning. So with Valletta, it is consists of 10 different countries, which kind of represents about 31.5% of the population in Europe. Yeah, and so the activities and the approach of Valletta has been considered slightly more disruptive in the sense that they have this approach of creating one aggregated joint market through pooled procurements for large volumes. And they were also the first group to implement the aims of the World Health Assembly resolution that called for greater price transparency in the medicine market. And this resolution was actually proposed and sponsored not just by European countries, but also non-European countries, most notably Italy, Brazil, India, and Malaysia, alongside South Africa and Uganda at the 72nd World Health Assembly. And moving forward with this resolution, the members of the Valletta Declaration were the first group of countries to have implemented the practical steps of the resolution to pursue greater transparency. And they have done so through an agreement to share their respective national prices. And this, however, has not reached any successful agreements thus far. So really looking at both the case studies, we wanted to observe and try and find the commonalities and lessons that we could draw from these case studies. And one thing that we did realize and observe, at least, is that Benelux had a prioritization on technical collaboration, and this was done through all stages of collaboration for specific products, while Valletta Declaration's collaboration is currently more political, and it is aimed to improve price transparency and produce a more competitive and innovative market. That, however, in itself does have its benefits. So just looking at both the case studies, some of the main benefits we observed was this culture of collaboration that allows civil servants in different countries to learn from each other. And bear in mind, this can be a very taxing task, considering the linguistic barriers, the diversity of healthcare systems, but it really is necessary in these types of platforms and collaboration to increase the trust between countries and civil servants. And it can be said that this can really be the building block to the success of any regional platform. And then the sort of more obvious benefits that we observed was, of course, established strategic collaboration on pricing and reimbursement, and sharing of information on policy solutions and best practices in relation to access to medicine. And this really can be seen through the successful joint negotiation of Spinraza through Benelux. So a few issues and challenges that we observed that can be sort of improved and considered moving forward is that, yes, it can be a taxing task for civil servants to deal with, but I do see that the sort of trust that is gained does triumph sort of that challenge in a sense. However, looking at the Valletta Declaration, I think the goal of moving all 10 countries together can be challenging, and more so for the main goal, which is to improve access. So the challenge of harmonizing joint assessment at national level can be very tricky, and this is based on the basis that there are different legal frameworks, different procedures and timing of assessments, and this could eventually delay and result in delayed access. And really bearing in mind that the sort of aim of creating these platforms is to improve access, so we really need to consider that the technical steps that are involved in improving access really need to be refined in order to produce positive negotiations. And this goes to my final point on how there is a need to sort of depoliticize these platforms and focus more so on the technical collaboration. So looking at the Malaysian context, Malaysia's cross-border collaboration for health happens through ASEAN and also APEC. And Malaysia has about 44 horizon scanning initiatives as of now. And this number may have been updated since I've last checked, but this includes identifying the effectiveness of rituximab, a biosimilar that is a drug for rare cancer. So moving forward, Malaysia can really start by initiating discussions on the sort of more initial steps of collaboration in looking at joint registry and information sharing. And this can really happen at an APEC or an ASEAN level. And we sort of need to go about having these discussions to begin with to really understand the feasibility of implementing practical steps. And as the sort of chair and host of APEC this year, Malaysia really has that very strategic position of being able to initiate and lead that discussion. Malaysia's participation as a co-sponsor to the 72nd World Health Assembly resolution on price transparency really shows this very important need of political will to move towards the direction of negotiation, which is promising. And other existing platforms through ASEAN can also be sort of tapped into to establish these platforms. I just wanted to, before I end, I just wanted to make a note of the fact that there are multiple areas of regional collaboration that can take place. And I just wanted to share, I'm not going to read this out, but I just wanted to share all the different points that have been put forth through the APED Action Plan on Rare Disease. These are all very valuable areas of regional collaboration that can take place. It is not just about improving sustainable access to medicine. Collaboration on research and development, collaboration on sharing of best practices in terms of diagnosis, collaboration on clinical expertise, and collaboration on social care delivery. There is a need and a much more dire need to not just look at healthcare delivery, but a more holistic aspect of improving access to mobility, education, and employment as well for this group of people. And yeah, I think that kind of brings me to the end of my presentation. I just want to leave with a few recommendations based on the case studies we looked at and based on the readings that we did. What we decided was that there was a few sort of key lessons that we can take away if Malaysia or this region was to sort of pursue regional collaboration on a more practical platform to improve access, sustainable access to innovative medicines. So one of the first things is that the countries involved should have a similar goals and similar level of development in regards to their healthcare system. Beyond that, there needs to be a level of flexibility of grouping of countries. There shouldn't be any sort of clear-cut need that in a specific countries over other countries, and there should be a flexibility of who would like to join specific stages of collaboration versus all stages of collaboration. And then there is this need of staged goals. So as we looked at the example of Spinraza, one of the main components that made it successful was the fact that it went through all the different stages of joint horizon scanning, information sharing, and joint HTA before proceeding to price negotiations. So there is a need to really look at the technical collaboration and have it happen on a staged in the basis of staged goals to really avoid any premature attempt of price negotiation. And that brings us to our last point. Joint collaborations are obviously very valuable. This coming together to share the different ways in which all countries are working towards improving access for rare disease patients is valuable, but in regards to implementation, we need to take into account the complexities of healthcare systems in respective countries, and we really need to look at independent implementation as a flexible manner in which this can happen, essentially. So I will end there. Thank you so much, and I will be leaving because I won't be joining the panel, but please do share your questions and I will try and answer them. Thank you so much. Back to you, Lawrence.
Great, thank you very much, Vaishu. As Vaishu just said then, please do share any questions, and I think Vaishu can try and come back on those specifically. And if anyone's interested to understand those issues in more detail, please feel free to download our policy paper, where we unpack those two case studies in some more detail. So now we're going to go back around Asia and hear three further perspectives on the situation in Asia. So I'm very pleased to start with Kin Ping Sang, who is the president of the Rare Disease in Hong Kong. KP is a retired business executive with retinitis pigmentosa and has been actively volunteering with patient groups for several decades, both in Hong Kong and internationally. In the 90s, along with fellow patients, he founded Retina Hong Kong, a self-help organization for patients with retinal degenerative diseases, and he has been the association's serving president since then. He is also the president of Rare Disease Hong Kong, which was formerly the Hong Kong Alliance for Rare Diseases, and he has been serving on the management committee of Retina International from 2000 to 2020. In 2008, he was elected to the governing board of the International Alliance of Patients Organizations and was the chair from August 2013 to July 2015. So he has extensive experience in patient advocacy and in rare diseases specifically. So we'll be very interested and grateful to hear about his extensive insights. So KP, I'll hand over to you, and Amir will be supporting you on the slides.
Thank you. Thank you very much. Morning, everybody. It is my great pleasure to share what Hong Kong has been doing in the past years on the advocacy of rare diseases. My topic today is to contextualize APED Rare Disease Action Plan in Hong Kong. And I will briefly share, firstly, what is Rare Disease Hong Kong. And the second one is the APED Rare Disease Action Plan. The third is contextualized APED Rare Disease Action Plan in Hong Kong. And then the summary. And the last part is the step forward. Okay, the next slide, we may see Rare Disease Hong Kong was established in 2014. We represent patients and caregivers and supported by academics, by professionals, by HCPs, and many other people in the society. And we have now about 500 members, covering about 140 rare diseases, 140 types of rare disease. And the next slide is our core works. We have 3 core works in Rare Disease Hong Kong. The first one is policy advocacy. The second one is awareness enhancing. And the last one is the capacity building. We try our best to train up more and more rare disease patient leaders so that our voice, our power would be strengthened to get our advocacy done. The next slide, you may see the APED Rare Disease Action Plan. You know, the APED Rare Disease Action Plan was endorsed in 2018 November by the APED LS Life Sciences Innovative Forum, LSIF. And the APED Rare Disease Action Plan has 10 policy pillars and 30 recommendations. That means each policy pillars has 3 recommendations, and also the plan has set out the indicators to achieve the plan. This plan is, I assume this is a good reference and good framework for the countries in this region to take our rare disease course step forward. And you can see on these 2 slides how Hong Kong has studied and reviewed the action plan, and to localize what is the top priority in Hong Kong and what is the key issues in Hong Kong. And then we will do our advocacy following on this as a basis of our advocacy work in Hong Kong. The next slide is contextualized APED Rare Disease Plan in Hong Kong. In March 2019, after a few months of the announcement of this APED Rare Disease Action Plan, we have held a forum in Hong Kong. We invited a great number of partners and stakeholders to review and study the action plan and how we can localize the policy pillars and the recommendations in Hong Kong. In July 2019, Rare Disease Hong Kong have a meeting with 3 pharmaceutical companies, namely Takeda, Sanofi, and Pfizer. These companies are very active in formulating this APED rare disease action plan in past years. We discussed the priorities, how we can prioritize the policy pillars and recommendations in Hong Kong, and how we can request the government to take lead to form a Hong Kong Rare Disease Action Plan. Next slide. In September, Rare Disease Hong Kong has forwarded a submission to the Chief Executive on the policy address. We have set out two core elements in our submission. The first one is to set out a steering committee on strategies of rare disease in Hong Kong. This committee should be led by the health secretary, and the members should be including the hospital authorities, the professionals, patient organizations, as well as the industry, the business sector. And the second core element is to set out the local definition in Hong Kong. There is still no definition of rare disease in Hong Kong. So this is another core element we ask the government to do. The next slide, you will see we raised 6 priorities in our submission to the government. And that includes likely the manpower planning, the genetic diagnosis, and drug treatment, and the coordinated care, and the Center of Excellence and Patients Registry. All these priorities and the core elements are responding to a specific policy pillar and recommendation raised by the APED Rare Disease Action Plan. And the APED Rare Disease Action Plan is a very good framework for us to do advocacy in Hong Kong. The next slide, we may see in mid-October 2019, the Chief Executive has delivered her policy address for the year. And in this policy address, she has announced 6 new initiatives on rare disease that's never has seen in Hong Kong, because in the past past years, the government has never give so much in new initiatives on rare disease. In these new initiatives, you may see it basically responded to our 6 priorities, but they speak in different phrasing or different terms. Likely, the government committed to build up the patients database, that means the registry, and to on the awareness, public awareness on rare disease, and to increase more manpower and deploy more resources for the coordinated care for rare disease patients. As well, it will put more resources in drug treatments, and the steering committee on genomic project will look into the undiagnosed rare disease by genome sequencing to accelerate the diagnosis of the rare diseases. The next slide, to summarize, the government has positively responded to our priorities, 6 priorities, although in different wordings and phrasings. And for 2 core elements, it has not agreed to do anything yet. And the government has explained for the definition, and it said the resources now is concentrated on clinical works likely to diagnose the patients, to treat the patients with the expensive drugs. So later on, it will collect the data and then to go into the more high level infrastructure, likely the definition and other mechanisms on rare disease. And for the steering committee, the government said, although the steering committee has not formed yet, but the patient organizations can negotiate, can discuss with the government at any time they want. So the door is open to patient organizations. Okay, I think this may be the last slide, step forward. This year, in our submission to the government, we have four key requests. The first one is to set out the timeline and indicators on implementing the initiatives it pledged last year, because up to now, the 6 initiatives the chief executive committed in 2019 has not yet fully implemented. So we demanded the government to set out the timeline. And the second request is to formally formulate the orphan drug policy in Hong Kong and to set out a clear guidelines how the government will enlist the rare disease drugs and give subsidize to the patients in its policy. And the third one is to re-emphasize the importance of the steering committee on strategy of rare disease. And the last one is to also emphasize the importance of to set out the definition, the local definition in Hong Kong. So we are moving on. The way that it is a long way to go for rare disease advocacy in Hong Kong. I think it's same in our other countries in the APED region, but I think we have to step forward, and we look for more collaborations in this region. Thank you very much. Thank you.
Thank you so much, KP. Very interesting to see the status of things in Hong Kong, where I recognize many similarities in some ways to the issues that we discussed in Malaysia. Okay, so from Hong Kong to Korea, and I'm very pleased to introduce Professor Dongwoon Han from Hanyang University in Seoul. So Professor Dongwoon is a professor at Hanyang University and chairperson for Global Health and Development. He was also chairperson of both the Department of Preventative Medicine and the Department of Medical Administration. He is also currently the director of the Institute of Health Service Management, and he has previously studied in Seoul National University and at the Graduate School of Public Health, and his doctoral degree is from the UK, from the University of Birmingham. Professor Han was also a member of the WHO Working Group for various health-related topics, including traditional medicine, and for many years he has worked as a short-term consultant at many developing countries in this region, including Vietnam, Nepal, Cambodia, Iraq, Afghanistan, Peru, Honduras, and so on. He has also advised the Korean government and local governments on health promotion, health planning, and ODA in health. Since 2004, he's been trying to establish public health programs in the public healthcare system. And finally, Dr. Han is serving as the director of the National Traditional Korean Medicine Research and Development Center. And from 2010 to 2012, he's also directed a research team for the evaluation of Korean case payment system funded by the Health Insurance Review Agency. So, Professor Hongwoon, we're very grateful to have you, Professor Dongwoon, we're very grateful to have you here, and over to you.
Okay. Good morning, everyone. I'm honored to be here to present some experience from Korean side. Today I just shortly overview the issues on the rare disease and what the South Korea effort on the rare disease since the 2000, and then what are the experience related to rare disease in Korea, and lastly, I just present some challenging issues for rare disease. The first the issues and the rare disease in Korea. The people in South Korea, they are concerned the severity of their disease and also their cost of the treatment and managing their disease. And also they wonder there are the accessible the healthcare and the social care services for them or not. And also increasingly in South Korea, we try to identify and the prevalence of disease because because of the modern technology developed, it influenced the identify the rare disease. We trying to learn and share the rare disease management from the foreign countries, especially the United States and some European countries. Still, we noticed the lack of proper diagnosis, and also the patient also desperate. They don't have effective treatment, and also the lack of knowledge is. So also the lack of researches as well. So since then, this slide shows that since 1973, the United States they start to manage the rare disease, but in Korea we started 2000, and then at the beginning 2001 we then started the medical expense support project we start, and then 2006 started an information system on rare disease, and also the 2015 we enacted the Rare Disease Control Act, and since from next year maybe just another program we start, because the first comprehensive plan for management of rare disease started in 2017. So next year we expect to know the outcomes of a plan, then we can improve the national policies and the management program for rare disease. So far the identified policies and the plans related to rare disease in South Korea, we can say there's 5 categories. The first is here some service support, and also medication supply and development promotion project, and providing information and development infrastructure, and some R&Ds related to rare disease. So this slide shows the research on the rare disease. This slide they try to establish the database using national health insurance database. So as you know, in Korea we have a very good national health insurance database. So then we trying to use even government facilitated to use the database, and then to develop some information, and then the support of the developing national policies. And also many of the researchers using the national database and the national program, and then we identify the prevalence of a disease. And also here also the undiagnosed disease program we have. So 1-year project pilot, they trying to identify the outcomes of health policies. So in the academic side, they investigate, evaluate the efficacy, the effectiveness of national policies on rare disease. So far, I just show you what the experience related to rare disease in South Korea. So far, every year we are facing the increasing the cost for the rare disease patient, and also the total number of the rare disease so far identified in South Korea, the more than 1,014, and also the total number of populations affected by rare disease more than 700 50,000 people they are suffering so far. So that's why so many patients with their families, with the rare disease, they are suffering some the identified problem, and also they need some kind of support from government. So national health insurance, their schemes, they develop some schemes for the covering their cost, and also they support by genetic diagnosis program for rare disease. It's very expensive, so government they will establish some infrastructures and the programs for helping them. This slide also my teams we just start some research on feasibility studies on establishing National Center for Rare Disease. We expect the future for public facilities for rare disease. So, and also since 2015, the clinical research network for 6 diseases was established, including histiocytosis, amyloidosis, and Crohn's disease. And also some epidemiology studies we did, and then every year the many researchers they evaluate and analyze the national data, and then we try to identify the total number of the victims from the caused by the rare disease. And also regulation of Korea in the disease orphan drugs. So we defined the definition of rare disease, the less than 20,000 people of disease for which the appropriate treatment and alternative medicines has not yet been developed. And also what the incentives we have for orphan drugs, so from 2003, we just stipulated exclusive marketing right for 6 years to encourage the research and development for orphan drugs. And also for the supporting system we have a supporting measures include the medical expenses reimbursement through the National Health Insurance Program. And also we have also the public fund that we allocate for the research on the rare disease. And also so far we established the public awareness program. So through the access to internet, we have a helpline for rare disease on the code, and also we have a database here. Then we can provide the information and to the patient researchers. So this is the component of public health policies on rare disease in South Korea. Under the Ministry of Health, we have 3. So one is the Open Drug Center, 1993. That is, we established this one, and then to help the rare disease patient. And also we have Genetic Rare Disease Center, 2004, we established it. And also the research grant since 2008, we allocate some budget for the rare disease. So, and also the 2006, Korean government established the reference centers of the 3 regional hospitals and nationwide. That is the main role is how to help them to get early diagnosis and very accessible counseling related to genetics, okay? And also how to prevent, also one of the key issues. And also the one of the role of the centers, education for public education, the patient, okay, and the paramedics and the professionals as well. So this is a slide shows some infrastructures of rare disease in South Korea. So under the Ministry of Health, we have a Korea CDC. There's a center for here, and also biomedical science and the genome science building, also under the Ministry of Health. And National Biobank of South Korea also we have, and also National Center for Medical Information Knowledge Center we established, and then we some hubs to spread the information to nationwide. And also we have a National Center for Stem Cell and Degenerative Medicines for the rare disease, not also rare disease, but also other desperate disease. So we so-called, we just move on now to some precision medicine approach. This slide also show you the recently since 2009, the Korean government they expanded the regional center. There's 10 centers nationwide. There's in Seoul. There's a SNU, National Seoul University is here. The green color. There is now the role is the Central Sport Center. That is they have many experience than other centers they share, and they also provide some workshop and also education training course sometimes, and then they share their experience the last few decades related to rare disease. So, and also we have a 5 helpline here. Then since 2006, then this is the web-based information. So the researchers, academicians, students, and also all the patient families, they can access, they can get information from easily from these centers. And also some research we do here. So like other countries, we just determine the priority of the research, and then the government they arrange some research. Then there's a public fund. Then many the academicians they apply, and then they get the grant, and then start the research. And also about the future challenge issues for rare disease, and future challenge issues here, there is a because of the rare disease characteristics of the rare disease, we need to share the experience. So and also we should mobilize more resource, okay? And also we need the very innovative technology. That's why we need a global network and the fund, and the new technology development is a very important issues. Still, we identified the national plan for rare disease in inappropriate some sense, and also we have also limited to the subsidy side to the patient in health policy in the rare disease. So that's why every year we renewing the national plan for rare disease. Still, the patient side, their family side, they're crying. Okay. So and also we also the suffering from the insufficient specialist. Okay, because in South Korea, from my research, once the specialist to be the competence in their research or the clinical the competence, maybe annually they need more than 50 cases per person, but because of the characteristics, they're very hard to we can get the specialist on the rare disease. That's why we need some network, and the collaboration is very important. And also some other clinical trial and the epidemiology as well. So recently the many research shows that nutrition is one of important factor to managing the rare disease. So that's why soon after the nutrition medicines, maybe soon after, maybe a few years within some medical doctor may prescribe some nutrition medicines for the patient. That's why the global R&D for rare diseases we need the innovative product, and the clinical trial we required, and also lifestyle change also very important for proper management of rare disease, and also still we have the lack of diagnostic tools. How we can develop and provide them. So this is identify barriers of developing medicines for rare disease, in the lack of expertise, okay, and the academic promotional systems, the access to funding, and also potential trial participant. Okay, so that's why we need the collaboration and the network and the shared experience on R&D is very important. Then we can ensure the innovative product for the direct tools for the rare disease patient. Okay? So that is my short overview of our Korea side. Thank you.
Very much, Professor Dongmoon. Very interesting to see the Korean perspective. So now we'll hear, oh, sorry, Dr. Dongmoon, if you could just mute your camera. Okay, so now I'm very pleased to introduce Dr. Naris Damrongchai, who is the co-chair of the APEC Forum for Innovation in Life Sciences. Dr. Nares was formerly the chief executive of the Thailand Center of Excellence for Life Sciences, a public organization with a mission to foster the life sciences industry, and he serves as the government co-chair for the Life Sciences Innovation Forum, APEC's leading initiative on health and health science innovation, and is also a committee member of the National Committee on Science and Technology Ethics. Nares is passionate about using his expertise in science, engineering, and management to transform the livelihood of people and to create a better society. So I think it'll be very interesting, Dr. Nares, to hear about sort of APEC regional perspective. So over to you.
Thank you, Lawrence. My name is Naris, and I'm speaking from Bangkok. On behalf of the entire APEC Life Sciences Innovation Forum, the APEC Rare Disease Network, and my esteemed co-chairs, I hope you and your loved ones are healthy and happy as the health, economic, and social challenges of the COVID-19 pandemic continue in Malaysia, in Thailand, and across the Asia Pacific region and the world. We're in this together. Before I begin, I want to thank IDEAS for the invitation to speak this morning. I want to personally thank Dato Sri Minister Baba and Tan Sri Director General Haisham for their leadership and participation in the 10th APEC high-level meeting on health and the economy last month. I want to thank Dr. Rohaizat for his kind welcome yesterday and his strong support of the APEC Rare Disease Network, which he so eloquently affirmed in his opening remarks. Dr. Rohaizat, we look forward to working together with you and our friends in the Medical Development and Pharmaceutical Services divisions to convene the APEC virtual consultation on COVID-19 and rare diseases in Malaysia, and the APEC virtual policy dialogue on rare disease in Malaysia and the Asia Pacific this December. We lastly want to congratulate the Ministry of Health of Malaysia and its esteemed leadership for their commitment to developing and finalizing a national rare disease framework and the associated policies, program, strategies, and interventions. We are very happy to hear that the APEC Rare Disease Network and the APEC Action Plan on Rare Diseases were helpful to your efforts. We look forward to Malaysia's continued participation and leadership in the APEC Rare Disease Network. Well, Asia Pacific is a regional platform bringing together Malaysia, Thailand, China, Hong Kong, China, and many more economies, 21 member economies altogether. We are accountable for 40% of global population, 50% of global trade, and 60% of the global GDP. Here's a map of APEC. So we are on both sides of the Pacific Ocean. And we often were asked by policymakers, if they are rare, why should we focus on rare diseases over more common issues? And here's the answers. To each individual economy, these are rare diseases, but to the whole region, to the whole APEC region, we have over 200 million people in fact affected, and mostly they are children and families. Rare diseases shines a spotlight on the gaps and barriers in our health system. So if we can solve these issues for rare diseases, it is very likely that we can improve the system as a whole. And when we think of rare disease policies, we realize that it requires a whole of the government, whole of society approach, and there are best practices that can be shared across borders, as we have seen in this session. So the APEC Rare Disease Network started in 2017. The APEC Life Sciences Innovation Forum has established the APEC Rare Disease Network to help economies to address the barriers to healthcare services for their people who live with a rare disease and their caregivers also. So then we started a tripartite cooperation between the government, academic and clinical experts, and the industries. And now we have a patient representative. The APEC Rare Disease Action Plan. It was developed by the APEC RDN and endorsed by the APEC Health Ministers in 2018. And the action plan establishes our vision in APEC and the aims to facilitate greater alignment of domestic policies and regulations. It supports urgent implementation of proven best practices and promote multi-sectoral collaborations and patient partnerships. Uh, we got over 70 recommendations, and we want to achieve 30 targets across 10 different pillars. I'm grateful for Mr. Tsang from Hong Kong, who has already reviewed these 10 different pillars. It starts from defining the rare diseases and orphan products with policies, process, raise public policy awareness of rare disease issues, promote innovation of R&D, build human resource capacity, facilitate early and accurate systematic diagnosis, and including newborn screening. It coordinates patient-centered care across medical and other health disciplines. It delivers new accessible treatments to patients, support financial and social needs of patients and their families, manage pooling and usage of patient data securely and effectively, and finally, to prioritize comprehensive domestic rare disease policy by integrating all the 9 initiatives, the 9 pillars into one. So what do we do with the APEC action plan? Uh, so the APEC Rare Disease Network is a regional and international platform. We then encourage domestic or our member economies by engaging with key R&D policymakers, and then have them in turn to use the action plan to engage with their patient advocacy groups and implement practical steps. This year, our timeline has shifted significantly due to COVID-19, um, and from distributed throughout the year, it now concentrated in quarter 4. And the network has conducted a survey of its member during June to August to examine the impacts of COVID-19 pandemic and response on rare disease patients and rare disease planning policymaking. We start to have positive results that will be shared in the forthcoming paper. The core focus is to support economies in implementing the APEC action plan, because in APEC, as we have seen, we have members like Korea who are very advanced. We have China, very comprehensive, and we see very good leading initiatives in Hong Kong, including association with genomics. But also we have to support all the member economies. So we are starting series of APEC virtual consultations on COVID-19 and R&Ds. We do that with Chile in October, Malaysia also now, Peru and Japan in November. And we work with Ministry of Health Malaysia to organize the APEC Virtual Policy Dialogue on rare disease in Malaysia and across Asia in November. We're working with MinSol, Chile, to organize the APEC Virtual Policy Dialogue also in Chile and Latin America. That will be in December. And we are working with the other parts of the APEC Life Science Innovation Forum, particularly the Regulatory Harmonization Steering Committee and the Harmonization Center to organize a virtual workshop on facilitated regulatory pathway. And that will also be in October. So the current composition of the APEC Rare Disease Network, we have a growing number of individuals and economies, and we have role for patients also. Right now, we have more than 300 individuals in the as members to date. Half of them are from government, 35% from the academia or clinical, and 15% are patients and civil society representatives. And we have now representatives from 18 member economies, and 13 of these are actually active and engaging with us. We have 4 companies in the rare disease network for now as the industry coalition: Pfizer, Roche, Sanofi, and Takeda. The network decided that it was important to have patient representative in the leadership, so we have added patient advisor to the leadership team, Dr. Durain Wong Reiger, chair of the Rare Disease International Canada. And here's the composition of the leadership circle. Our chair is Professor Matthew Belgard from Queensland University of Technology. Myself as government co-chair. We have a co-chair, academic co-chair, Professor Xiao Ying from Peking University, and Sanofi, Mr. Scott Williams from Sanofi Genzyme as co-chair, industry co-chair, and our patient advisor, Dr. Durain Wong Reiger. Next year, our core focus will be to support economies to further implement the APEC action plan. So we are engaging with the stakeholder consultations to be conducted in Japan early next year, and the policy dialogues, 2 likely planned for next year also. We intend to go deeper and broader and have cooperation across the Life Science Innovation Forum and beyond the forum. Okay, I think that will be it. And this is my final slide with a picture of all the member of the APEC Rare Disease Network at the policy workshop. And so the team is expanding. And I'm very grateful and happy to hear the implementation of the action plan by Hong Kong, China today. So that would be all from me for now. Back to you, Lawrence.
Thank you very much, Dr. Nares. So we now have officially about 30 minutes, but perhaps we'll overrun again just to go through some questions. So I've been keeping an eye on the Q&A, and I'll try to cover all the issues that have been raised, but I'm going to add a couple of my own questions. And I actually want to start, I want to come straight back to you, Dr. Nares, because I think when we look at the APEC action plan, I think we see a very credible and kind of well-designed action plan. And I think that that's a really helpful framework. And I think, as we saw from KP's presentation, it's been a useful tool to drive progress in Hong Kong. I think, we've also referred to it here in Malaysia. So I just wonder how you foresee that, oh, sorry. And if I could just ask for all the panelists now to switch back on their videos so we can see everybody, that would be great. So I just wanted to ask Dr. Nares how APEC is going to strike that balance between a collaborative approach that respects, the individual needs and sovereignties of the countries with pressure to implement the agreement. I think, I haven't worked as much on APEC mechanisms, but looking at ASEAN agreements, you get these really great agreements, but then does it get implemented on the ground? So I wondered, perhaps specifically, would APEC produce like a scorecard of which countries have kind of delivered on time and so on, or how generally are you going to handle that side of it? How generally are we going to make sure that countries stick to these agreements? Oh, I think you're still on mute, Dr. Nares.
Again, thank you, Lawrence, for the question. You say like it's a kind of friendly competition, which in fact it might be. To use the word pressure might be a little misleading because APEC is actually a very, very voluntary forum. And we only encourage and try to help those who really aspire to bring about the changes to the system. And we use examples actually, like I myself attended the China last year conference, and I was very much inspired by how China has bring together patient groups. That was very, very evident for me. And Thailand, we worked in Thailand by inspired by what we saw in many different member economies to start our own conversations within the system of Thailand. And very luckily for Thailand, which is my own country, we had established a universal coverage system a long time ago. So it fits well with the timing. I think the timing was right. Once you have that system in place, you have more confidence to move on to adopt the government policy. And in Thailand, we have a policy of leaving no one behind. So even though the basic principle for UC is that to give the resource for diseases that are most prevalent, but we also have the rule of rescue, because as I said, rare disease is smaller in number. It does not consume too big a resource, but it can rescue the people who are really much in need, and that provide a good example and actually a moral support to conduct further whatever research development and provide health service to the people who are really much in need. So I think it's fair to say that it's a very, very healthy and friendly competition.
Thank you very much. I think it's a really useful platform, and I think it will be very interesting to see how each country takes that forward and how we can use that to drive progress. I think on that note, I'd like to pivot back to Dr. Eileen, because I think everyone was quite impressed by the level of activity and the rate and the speed of the change in China, and then how you're kind of learning some of those lessons and applying that to the regional work. So I know you answered Dato Hatice's questions already on the chat, but I just wanted to come back to some of those points, which were really how you were able to get the level of buy-in from the different stakeholders, and what do you think are the good lessons in terms of building that kind of really impactful national effort? And connected to that, how did you also work constructively with industry? Because I was quite interested by what you said when you started talking about bridging that industry gap and even stepping in to do things like patient registry, which is something that keeps coming up in the Malaysian context. So it would be very interesting, just you could tell us a little bit more about how you built that buy-in, and then how you use that in particular to work with industry.
Yeah, thank you, Lawrence. I think it's all accord we have done in the past 3 years a very critical transition. I think before, back 3 years ago, actually at that time in China market, the industry engagement is not that strong. But in the recent 3 years, we think we are trying to re-establish the ecosystem in rare disease community. I think the first thing is to identify the critical unmet needs from each side, from the pharmaceutical industry side, from the government side, from the physician community side, the clinical side. So the first thing is to identify the pain points from each stakeholder groups. And the core that we have done a lot of research on this. And also we have invited players from each side to join the court as our internal consultant. For example, currently in court, we have consultant from the CRO side, from the consulting group, from the pharmaceutical industry. We are very open to invite them to join court as our internal consultant, tell us what they're thinking about. So it's the first thing. And the second thing is to establish the platform to have the communication with these multiple stakeholders and to provide high quality content to respond to their unmet needs. So I think it is not that easy to do, to realize, but still there are a lot of methods. For example, I have mentioned about the 3 white papers. It is not conducted by court on its own. We cooperated with IQVIA, which is a consulting firm. They're providing professional consulting services, and they know the industry, they know the client's requirements. So to provide high quality content means we need to cooperate with professional organizations to do professional things. And also another thing is to know more about the pharmaceutical industry. That means know how they spend money on rare disease, how they expect to achieve in rare disease, and what are their hurdles, challenges. And I noticed that somebody mentioned the funding question. It is critical for patient organization, how we can obtain continuous and also containable support from the pharmaceutical industry. So in the previous years court, we have done a lot of pharmaceutical engagement, but basically speaking, that is not that efficient. In the previous years, most of the funding from the industry side are very limited because when they connect with patient organization, they are using the so-called public relation department or the patient access department to connect with us. That means our funding will be very limited because it's a very limited corporate funding source. And there, in the past 3 years, we started to engage with the industry business unit. That means we are using different funding source. And then we can see that in the past 3 years, when we do the white paper studies, we can obtain more funding from the business unit. And that means that can be much larger than the previous patient projects collaboration. So we need to change the engagement on site, change the connection points. This is the second thing. The third thing, I think in the ecosystem, physician part is also very critical. In the previous years, we started to do the patient registry, but the patient registry without the physician does not make sense. That means we do the patient registry, but that shall be used by HCP for them to do the research work. And that shall be used by the industry to do the insights exploration work to understand more about the patient community. So, so in this understanding, we are perfecting our patient registry system based on the industry needs, based on the physicians, based on their research needs, to perfect the system, to make it more comprehensive, more professional, and it can be extended to more purpose in the future context. And also we have identified that physicians in the previous year in China, we have a very historical problems among HCP and the patients. In China, resources are very limited. So previously, historically, patients, they are more likely to be kind of, they have a lot of concerns about HCPs. They have a lot of complaints about HCPs, and also HCP have a lot of complaints about patients as well. So in the past years, we are trying to establish a more friendly context between HCP and the patients. We educated HCP that patients can also support you to do the research work, but we play as a professional role to bridge the needs from both parts. We tell patients what the HCP needs from you, and you can work together to promote the rare disease, the overall social awareness, and also to have more resources from other sides. And also we have identified that HCPs in China, we can do a very precise segmentation. The most key opinion leaders, maybe they don't have time to do the research in rare disease, but if they are the senior physician, for example, the associate director, not the director, meaning the rising star physicians, they will be a more appropriate target for rare disease community. That means they are humble to learn more about rare disease, and also they expect to have some breakthrough research in this area for their personal development, for their personal reputation in the clinical community. So in the past years, we continuously to identify the so-called rising star among the community, clinical community, and help them to obtain the support from the patient community, and then help them to have more high quality research works. And we also even help them to establish a new branch of, for example, a single rare disease like Huntington disease, like that, for them to have some social influence. And then more and more HCP, they can see this. So they will be attracted by our work, and they will go to us for help. Like, Cord, can you help me to connect with a broader community of the disease community of patients? Then we can do some, like, for example, real-world evidence study, or very forward-looking clinical study like that. So I think the key to form the active multi-stakeholder or industry engagement or clinical community engagement, the key is to you identify their key unmet needs and provide high quality outputs for them. And also then you can form a cohesion in the ecosystem among different stakeholders, and they recognize your work, and then they will go back to you again. So I think just the key is to provide high quality outputs and resources.
Thank you so much. That's really, really informative, I think, and I'm sure I think we'll have many patient groups, organizations that are here today, and hopefully there's some interesting experience to take from that. I'm going to just move to address a couple of questions on prevention, and I'm going to ask Professor Dongwoon to comment on this, because he mentioned that government in Korea has also highlighted prevention as part of the rare disease management and strategy. So I'd be grateful if you could comment specifically on how that prevention is being taken forward in Korea. And I'm just going to also put this question to you, which is that genetic screening and for newlywed couples and newborns is crucial for maintaining prevalence and future treatment. So how is this being addressed? I mean, specifically in the Korean context, but also...
Yeah, in Korea, the government, they highlighted the cause of rare disease is almost more than 80% of rare disease from the genetic disorders. So just we mentioned in the the family histories or other any the issues related health, then the genetic counseling is very important. So government, we raise some fund, and then encourage people to get the free genetic counseling services, and also some cost for genetic analysis also they funded by government. So then we encourage them, even the local hospitals, we especially the Department of Pediatric, we issues from government side, they just ask them to register some suspicious patient, and then they can report attend the designated the regional centers. Okay, then they can arrange, and then they be there, and then they can get counseling and to prevent the further the issues.
Thank you so much, Professor. And I just wanted to ask a follow-up question, which is a bit broader, which is, I think you presented quite a comprehensive account of what Korea is doing, and as Dr. Nara said, Korea is quite developed in this respect. I think when we look at the APEC, there's different levels of political will or there's different levels of readiness to implement comprehensive rare disease policies. What, in your perspective, was it that kind of convinced the Korean government to take that clear action? What was the balance of patient-led advocacy or kind of regional comparison? What was it that you think convinced the Korean government to implement all these actions?
Actually, our history is not so long, maybe almost 20 years. So at the beginning, the Korean government very rely on expert group. They treat some patient, and then they said, oh, I'm the expert in the rare disease. But once we contact them, and then what are they experienced by the few cases, then mostly in Seoul there is a big hospitals located in Seoul. So the Department of Pediatric, maybe they can get more experience from the patient. And then the Minister of Health, they accommodate the whole data and the experience together. And then they ask them what the next plan. And then the expert group, they provide some free consulting at the beginning. And then actually 2018, Korean CDC, they established establishment of the rare disease department. They appointed the directors since then, maybe not so long. So even though we have 20 years, the government, they concerned the cost of the treatment. That's why when the patient visit any clinics and hospitals, and then they diagnose it as any kind of the rare disease, then they can, the doctor side also, they inform the patient that you could register as a rare disease, then you can get benefit from the Minister of Health and also National Health. We have a National Health Insurance, means the public insurance, so then they can benefit from them. And also after they registered, then they also the information shared with the public health centers, the nationwide. Okay, then some government policy change, then the national public centers or the hospitals who registered that hospital, they also inform them about the new changes, what a benefit from government. So including some genetic counselings and genetic diagnosis, and also other some benefit from they could not get any of the information, then it's very hard. So all the informations we digest and then provide them, and then they can maintain and improve their quality of life. So also the recently the minister, the parliament also, they develop some registers, make them laws for managing and control the rare disease. I'm doing some now establish how to establish national center for rare disease. Okay.
Thank you very much. No, I think it's very helpful to hear that experience and how the different parts of the government were able to champion and then pull the other bits up in order to achieve that kind of system-wide success. I want to just address a few questions that have been raised that we also touched on yesterday, which is that the fact that within the rare disease community, we have the problem of orphan drugs and the high cost treatments, but also that that's actually only available for some, a subgroup of patients, and that for many patients there are no treatments. But then they also have, obviously, huge numbers of unmet need. So I think this is something that when we're discussing both in a policy context, but also from an advocacy perspective, how do we balance those different groups and their needs? So perhaps I can turn to KP to ask, in your experience over the years in Hong Kong, but also internationally, how have you sought to balance advocating for a policy on orphan drugs versus, or in the context of broader improvement of the quality of life for rare disease patients, even where orphan drugs do not exist?
Thank you for the question. I think Hong Kong is maybe something different to many countries in APEC region. Hong Kong is a wealthy city. Hong Kong has rather sophisticated and responsive public health systems and services. However, when we talk about rare disease, it is definitely defects of Hong Kong. We always talk about no one is left behind, but Hong Kong is left behind on the rare disease policies. And I think the problem in Hong Kong is not money. The chief executive of the Hong Kong government has said many times, money is not the main problem in Hong Kong. The main problem in Hong Kong is the policy and the mechanism. Yes, always some people ask, if you input $10 million for common disease, you may save thousands or even 10,000 of patients for common disease. But this $10 million may only save 1 or 2 rare disease patients. But when we argue with the officials in Hong Kong, we said this is not a topic in Hong Kong, because Hong Kong can afford not only 10 million. It can pay 2, 3, 4, or even 5, $10 million. So the main problem is the political willing and the attitude on rare disease by the government and the government officials. Of course, I think in other countries, resources may be constrained, in particular for common disease and rare disease. And I think China has very good sample. I just attended 2 conferences in China in September and October. And they have now initiated some co-payment campaigns. That means the insurance system may bear some of the fundings, and also the charity funds and the local governments, and also the patient themselves. So it is a good model, I think, for some countries that the patients can pay part of that, government pay part of that, the insurance pay part of that, and also the charity funds can do that. So I think maybe Eileen can share the model or the samples in China.
Thank you very yeah, thank you very much. I mean, I agree. I think the China case is very interesting. Dr. Eileen, do you want to just make a quick comment on that?
Yeah. I think we just published a report on the high-cost drugs solution in China. The first thing is the government-dominated basic medical insurance plus a multi-tier payment. We think under this system, the rare disease drugs under 2 million annual cost can be solved actually. 2 million RMB per year, which means I think is likely. it's like 300,000 USD per year. We think it's solvable. And the second thing is to propose a national rare disease fund, like Australia, like Russia, they have done in the past. So we think with the national fund with like 4 to 15 billion RMB per year, they can solve the in-market ultra rare disease drugs problems. So we think with the two solutions, we are very positive in the next 5 years. The high cost of very expensive rare disease drugs, the payment problem can be solved in China.
Thank you very much. Just because, I mean, it's interesting because this is kind of back to kind of some of the things we were discussing yesterday, but I just want to pick back up on that. And KP, just ask you if you could clarify a little bit about the model you described for funding in Hong Kong. So you talked about how you bring together these different funding sources, you know, patient, government, insurance, charity. Could you elaborate a little bit on how that works, or is that system not in place yet?
Hello. Hello.
Hi, yes, we can hear you. Yep.
Yes. Okay. In Hong Kong, the government supports some very expensive rare disease drugs, such as the Spinraza. It's about 6 million Hong Kong dollars per year for one patient. And the model is that we have also the co-payment mechanism in Hong Kong. But the co-payment is not based on the price of the drug. It is based on the affordability of the patients. So we have the calling means test. That means the patients may declare his or her disposable assets, and then the government will calculate how much the patients should pay for the drug. Like the Spinraza, 6 million Hong Kong dollars per year, for some patients, they pay zero because of their economic status. They are in the grassroots classes, and for some middle class patients, they may pay several thousand or 100,000 Hong Kong dollars per year. It is not significant to their disposable assets. So this is a principle in Hong Kong to co-pay by the affordability, by the disposable assets of the patients, but not based on the price of the drug.
Thank you so much, KP. That's really helpful. I mean, we are sort of about to run out of time, but I'm just going to go over by a few minutes just because I've got a couple of other points I want to pick up. But so I think one question I want to ask is about, so during this discussion and yesterday, COVID was mentioned a few times. And I think that it's interesting because COVID-19 is unprecedented in so many ways. And I think a point that one of our panelists made yesterday is it has shown where like it's kind of forced society to make judgments about protecting vulnerable groups in ways that we probably didn't anticipate. And I think that I was really interested to see in Dr. Eileen's presentation how, you know, our rare disease advocacy has partnered with, you know, has tried to kind of share a stage, as it were, with COVID and not use COVID, but to highlight how COVID, you know, intersects with rare disease vulnerability. And also in Dr. Nara's presentation, on the other hand, we pointed out that, you know, COVID is, the risk is that COVID as a healthcare issue kind of dominates the attention of policymakers fully understandably. So I think there's a really important balance to strike there. So maybe I could come to you, Dr. Naras, just to ask, you know, at the APEC level, how do you anticipate kind of balancing the need to have COVID discussions, but also use COVID as a way to highlight other vulnerabilities in our health system, such as rare diseases? I think you're on mute, Dr. Nara.
Once again, thank you, Lawrence, for the question. I think, as you said, COVID has highlighted I would say, vulnerability. Well, from what I experience here in Thailand, we seem to think that we have a very good health system, but on the other hand, we realized from the COVID pandemic how fragile we are in some parts of our system. It's like we are on a ship where, you know, water is leaking in, and we realize, because COVID was the water that came in, because we didn't realize that before. On the other hand, it's very depressing to see that most of the medical resources were allocated to COVID-19 in some way even more than suitable. So we have some local discussions, and you ask about the APEC level, how to strike the balance. Actually, we did, as I said, a survey of COVID-19 and rare disease. I would like to save that because it's still in a draft, and we will make available this report to the public in no time. Thank you.
Thank you so much. Okay, I'm going to need to draw the discussion, I think, to a close, but I'll just ask for each of our panelists maybe to just provide some final comments in turn. And I think the question I want to direct to you, but feel free also to add any other points that you think haven't been made. The question in the box from Nadia is about how we identify sort of political champions. I think we heard in the Korean example how different parts of the government machinery effectively became champions because they developed experience. We've heard in the Chinese case how identifying clinical champions and supporting them. But I think underpinning all of this has also been the question of political will, and how do we also create political champions to promote RD. So I'd be very interested in some sort of final comments on that question, or any other issues that you want to comment on before we close for today. So maybe I can start with Dr. Eileen.
Yeah, sorry, I think I just missed the question.
So I was just asking how we cultivate champions to promote RD, or anything else that you think we can do as a sort of immediate step to improve regional collaboration on RD.
APED, we have a 3-year plan, which includes to promote the regional level national RD action plan as well. I think next level, maybe we can have more communications like focus groups to discuss of the domestic RD national plan, and then we can share the opinions of the previous experience, and like which kind of activities actually is not that feasible, but which one is more urgent or more feasible to do that. So I think first one is every country or market region, we can have our own national RD action plan, and we can take that to the like more international platform to have more communications, and then we have clear like milestones, KPIs to check if we have meet the expectations, and to have more audience and observers, monitors to help us, to stimulate us to pave the things forward looking.
Thank you so much, Dr. Eileen, and thank you for taking the time to join us today. KP, if I could ask you for
Yes, I fully agree with you, Lawrence. We need the political champions, either in the individual economies like Hong Kong, like Thailand, like Malaysia. I think in every country, different sectors are working on rare disease. But I think better coordination on making best use of human resources and the fundings should achieve more if we have political champions in each country as well. If we have a political champion on APEC platform, that would be much better than now in the region to work on rare disease. That's my last comment.
Thank you very much, KP. Professor Dongwoon, your closing remarks and your thoughts on how we can improve regional collaboration.
Yeah, actually, even 21st centuries, many the health policy expert group, they worry about how to ensure the quality of care and the cost of the care and accessibility of care. So, from the Korean experience, we have a very well developed social security systems. So, and also there's many active patient advocacy groups. So in Korean experience, we have the grassroots level, and then top, we just ask government to do something, not top down. So still the related to the rare disease, the stakeholders in the patient with the rare disease with their family and their communities and the advocacy groups, NGOs, and also the healthcare professionals. Also, they are another support group, and also the community level, for instance, there is sometimes they have a need. They are crying. They need more resources. Then we can contact the local MPs, okay, and then they discuss with them, and then why they don't make some law and amend the law to relate rare disease. Currently, in Korea, also one of the local province, the local GPs, province GPs, they are the MPs groups. They announce the next 4 years, I will do something. It's just a political will like this. So we just integrate all the effort together. Then we can develop a more sustainable health system for rare disease in Korea. But also because of the characteristic of their disease, without the international cooperation, collaboration, we could not make a good the result. So in the South, Korea and Japan and Taiwan, in China, and also the Malaysia, Taiwan. So it's not even Thailand there. So maybe in a sense, we share the national health insurance systems, for instance. Then how we can utilize that in a social security system for the health, the rare disease. That is very important. So, but from yesterday, we have the financial issues, some political issues. Today, more practical issues related to the systems. But maybe we need some good platform to share and collaborate each other.
Thank you so much, Professor. And I'll give I know Dr. Nares has to leave for the next conference, so I'll just give him the final word on next steps on regional collaboration.
Thank you, Lawrence. I think I would put patients and patient group first. I think they will be the most important group of people, the key to drive our rare disease network forward. I am thankful for our industry partners, Pfizer, Sanofi, Takeda, and Roche. They've done an excellent job. We meet very frequently in Thailand and elsewhere. And since I'm sitting here in Bangkok, Thailand, I will also like to show my appreciation to our people who work very hard in our system, people from HITAP, our health technology assessment program people, the Health System Research Institute, Ministry of Public Health, our medical school, especially Dr. Churchai from Sirirat Hospital, and Dr. Duangreddy from Rama Hospital also. And finally, I would like to say that, well, you know what's going on in Thailand right now, and there's a big debate. So I would like to say that, I would like to quote actually, Mr. Chuan Lik Pai, the president of our parliament, who said that we cannot make everyone equally rich, but we can make everyone equally treated under the law. So I think I myself am determined to see this happen across APEC if possible, but at least starting from Thailand where I live. And I think one of the big passion for me apart from having democracy and justice, is to help people with rare disease to be equally treated under the law. Thank you very much.
Thank you so much, and a very inspiring note to end on. So I'd just like to thank all of our panelists for providing sort of these deep and varied insights from across Asia Pacific, but I think some of which resonate with Malaysia, some of which are new for our context, but all of which are helpful to inform our understanding and better equip us to continue to try to advocate for exactly what Dr. Naresh just articulated then, a kind of a right to equal treatment under the law. So before we conclude the conference, I will just introduce our CEO, Trisha Yeo, to provide some concluding remarks on this wide-ranging discussion. Over to you, Trisha.
Thank you, Lawrence. And thank you, stupendous panel for today and the last 2 days. I'd just like to thank once again Yang Berbahaya Datuk Dr. Haji Rahaizat, Deputy Director General of Malaysia, of Malaysia's Ministry of Health, Dr. Eileen Lee, Director, Asia Pacific Alliance of Rare Diseases Organization, Kin Peng Sang from Rare Diseases Hong Kong, Prof. Dong Woon Han from Hanyang University, South Korea, Dr. Naresh Damrongchai of APED, LSIF, co-chair, my colleagues, Lawrence Todd and Vaisnavi, APED Rare Diseases Network members, patient groups, MOH policymakers and industry in Malaysia, speakers and attendees from around the region, Malaysia, Thailand, Australia, South Korea, Hong Kong, China, and beyond. I thank all of you for joining us over the last 2 days. I'm just going to keep it as short as I can, but just some things that struck out over the last 2 days. For me, I was struck by what Dr. Naresh has said today, that over 200 million people are affected by rare diseases, mostly children and families in the APED region, and that therefore the policies need a whole of government response. Certainly that is the main reason that we're all gathered here today, as well as yesterday. I trust that you've had a really good conversation. Just to repeat a few points from yesterday. Yesterday, we launched our policy paper on the next steps for rare diseases in Malaysia, improving access to treatment. And we looked at the factors to be considered if Malaysia pursues a rare diseases trust fund. We talked about the details required to get the trust fund right, and why pursue a trust fund. In short, because we know that treatment for rare diseases is expensive, and it reduces access to patients suffering from rare diseases. But there's a need to balance between cost effectiveness and equity. And we know also from our speakers from yesterday that even if we do have a trust fund, this still does not mean that the government should escape from its own accountability. It still needs to work through the healthcare system, ensuring that the healthcare system is one that is updated, and patient groups still need to be involved. So that was yesterday. And today, of course, our distinguished panel has talked about the benefits of regional collaboration. And it is also recommended, and we issued a statement yesterday saying that Malaysia should also embark on this too, for many reasons, as pointed out in the presentation by my colleague earlier. This would enable us to have joint information sharing, joint horizon scanning, joint health technology assessment, joint price negotiation and procurement, and the list goes on. I think the collaboration is quite clear. This has benefited Europe, and there are some examples that were presented earlier that show that this could also help Malaysia as well as countries in the APED region to strengthen our own knowledge and negotiation, procurement, and so on. So what would we collaborate on? On R&D, on education, mobility. This would increase the trust among the various partners. And I'm happy to see that the APED Action Plan on Rare Diseases already includes collaboration on, for example, clinical expertise. So it is clear moving forward that collaboration will be needed from all stakeholders to get this right. Doctors, patient groups, pharmaceutical companies, governments, academics, regional platforms such as the APEC continue to provide the necessary rigor needed to champion for the rare. Just to close and just to zoom out a little bit, from the perspective of ideas in Malaysia, we have been having a championing for the rare project all the way from 2018. So it's been a long 2-year process. It's been an interesting learning process for us, where we have the main objective of to raise public awareness and support And secondly, to develop and advocate for a national policy in Malaysia by building these coalitions with relevant stakeholders. This year, we worked hard to put together the paper that you just saw yesterday. And this has all culminated in yesterday and today's regional conference. I think just moving forward, specifically for Malaysia, we know that the National Framework for Rare Diseases in Malaysia is being pursued by the Ministry of Health. But just to take off from the last point that was said by the panel, the question is, who will the political champion be at the regional level as well as within the country? And we do hope to see that political champion emerging out of these discussions. With all this, it is my hope that, again, reiterating that rare disease patients in Malaysia and the region will one day soon receive the affordable and accessible treatment that they need through these robust and sustainable rare disease policies that can be achieved through regional collaboration platforms, ultimately for the sake of those children and families that are suffering from rare diseases. I also note that the APED Rare Disease Network will be partnering with Malaysia as the chair and the host economy this year to organize the APED Rare Disease Policy Workshop that I believe is scheduled for December 2020, although the date is not confirmed. So with that, once again, I'd like to thank all of you speakers and attendees for staying with us throughout on a highly technical but yet highly interesting and relevant topic. And with this, I officially close the two-day regional conference on rare diseases in Malaysia and Asia Pacific. Thank you for joining us and spending your 2 days with us.
Thank you so much, Trisha. That marks the end of the conference. For those of you who weren't able to capture the whole thing, I'll just say that the recording will be available on our Facebook site, along with the link to the paper, and I'm sure we'll make the presentations available as well. So thank you, everyone, and thanks again to all the panelists, and please stay safe and please stay engaged in this rare disease discussion. Thank you very much.